Thank you, Paul. Next, again, think of questions because certainly we'll have time in the panel discussion at the end of these first four talks, four questions. Next up is Dr. Sean Bhalla, an assistant professor here, one of our advanced endoscopists. Our division was really happy and excited for Sean to join us from the University of Miami last year, I guess.
Yeah.
Yes, and he came all the way back to Denver from Crested Butte just to give this talk, believe it or not. He'll be talking about chronic pancreatitis. Again, Dr. Bhalla is going to be one of our course directors next year as well, which is really exciting. Sean, thanks.
Thank you. All right. Thank you for having me back this year. And I guess next year now too. Thank you all for joining. And you're very lucky because you get to listen to chronic pancreatitis on a Saturday morning. And I'm sure many of you have taken care of chronic pancreatitis patients. And I do this on a routine basis. And I also sometimes get very frustrated with a chronic panc patient. And so I'm hoping today we can kind of discuss how we manage these folks and we can simplify kind of diagnosis as well as treatment. So let's get started. I don't have any disclosures. These are our learning objectives that we'll go over today. And what I really want to emphasize is that chronic pancreatitis is no longer just an alcohol-related disease. And that's how it's been thought of for a very long time. But, it's a complex fibroinflammatory disorder that requires multidisciplinary care. And, I think if that's our big takeaway from today, I'm hoping that can really help a lot of our patients in getting the treatment that they need. And so trying to figure out how to best explain chronic pancreatitis, I turned to our AI friend and asked ChatGPT to describe chronic pancreatitis as a cartoon. And, this is kind of really what it's like for a lot of our patients. It is a silent destroyer. Patients are really suffering from severe pain and can be quite symptomatic as the pancreas continues to get destroyed. And as you can see here, kind of gets summarized quite nicely as to what happens and kind of our risk factors, consequences, and management. But what I really liked is that it's irreversible damage, relentless pain, but early recognition can lead to better outcomes. And I think this is really important. And where we struggle with this disease is, unfortunately, a lot of the patients that we catch are too late. And my hope is that, as our research progresses, we'll be able to find these patients sooner. But are there things that we can do? So let's talk about chronic panc a little bit more. And the global incidence is actually fairly high, 10 per 100,000 person years. And the prevalence has a wide range. Men will suffer, unfortunately, more commonly compared to women. And there is an upward trend in the United States and globally of the patients that are suffering from it. And so what is this progressive fibroinflammatory syndrome? It leads to destruction of the pancreas parenchyma, chronic pain, pancreatic insufficiency, diabetes, type 3C, which is basically destruction of the islet cells in the pancreas related to pancreatic issues. There is an increased pancreatic cancer risk, and this can have a major quality impact for our patients and also leads to larger healthcare utilization. And so what's the pathophysiology behind this? And in these patients, there's repeated injury, and this leads to persistent inflammation. And over time, the pancreatic stellate cells get activated, continue to digest and break down the pancreas, leading to collagen deposition, fibrosis, and then basically loss of cells. So our acinar cells get destroyed, which leads to pancreatic insufficiency. And then you can also get loss of islet cells, which leads to endocrine disorders. And throughout this, patients are suffering from chronic pain and pancreatic insufficiency, which we'll discuss. But the big thing to note is the pancreas has a huge reserve. So when patients are becoming symptomatic, 90% of the pancreas has been destroyed. And so this is kind of why patients are caught very late. And it's at 90% of damage where patients will have clinically apparent symptoms like steatorrhea and vitamin deficiency. So let's talk about kind of what our differential is and what the cause is. So if you remember this acronym TIGER-O, this will go over kind of the major causes of chronic pancreatitis. And so when I see patients, I kind of have a checklist that goes over all of these things to ensure that I've covered all of this for my patients. So that includes toxic metabolic, idiopathic, genetic, autoimmune, recurrent acute pancreatitis, and then obstructive etiologies. I'm not going to go over all of these in detail today, but just highlight a few. But the biggest category, I think what's important in toxic metabolic is looking at alcohol and smoking. And so for both of those, the big thing is alcohol only accounts for half of the cases. So taking a good history is really important. Just saying someone drinks isn't going to cover it all. Is kind of their history is quite critical. And then smoking is also an independent risk factor. We often just, people have been smoking for 30 plus years, they are going to be at risk for chronic panc, and that alone can do it. If it's idiopathic as an etiology, is it early onset? Because that makes you want to think, do I need to go to genetic testing, which we'll talk about on my next slide. Autoimmune pancreatitis can be easily tested for, especially when it's IgG4 related disease. And then taking a good history on if they've had recurrent bouts of pancreatitis, what has that occurred from? Why did it occur? Is it anything that's on this list or not on this list? And then finally, obstructive. And as a therapeutic endoscopist, that's where kind of we shine, is if there are some obstructive physiology that's causing their pancreatitis, is there something that we can do? And I think, most notably is if there is strictures or stones, we can treat those. And then also you want to make sure, is there a localized mass that's causing obstruction? Is these patients are at higher risk of pancreatic cancer, which we'll talk about as we move through the talk. So genetic testing and why this matters is, patients, some of these folks have been through multiple providers and they want to get an answer. And so I think that's the big question as to why should we test, is that we can kind of tell them, hey, look, this is the cause of your chronic panc. It can kind of end this exhaustive, invasive testing and diagnostic hunt. It can also be helpful in making a decision for TPIAT, which we'll talk about, which is a total pancreatectomy with islet autocell transplantation. It can be helpful for family members and then also speak to, increased pancreatic cancer risk. Now, who should we consider testing in? I would say young folks, as well as folks with a family history. And if they've had idiopathic recurrent cases of acute pancreatitis, those are the people we want to be thinking about. This is from the ACG guidelines on chronic panc. I just put this for our reference. We're not going to go through all of them, but these are the genetic polymorphisms that exist that affect chronic panc and how they're displayed. But the big takeaway is, if you are considering genetic testing, is getting consent from patients is really important. The cost, that most insurers will not cover it. So it is a private cost, depending on which testing you use, can be anywhere from $200 to several $100s. And then finally, are there consequences for any genetic testing, whether it's for life insurance, other insurance policies? Could that change outcomes for our patients, and could they be dropped from insurance? We don't really have good answers for that. And so I think discussing that with your patients before you go into jumping into testing, I think is really critical. So how do these patients present? The main one is chronic abdominal pain, weight loss, steatorrhea. They may have new onset diabetes, and in some severe cases, new onset malnutrition that's been going on for some time. You may find muscle wasting in these patients. They can have, fat soluble vitamin deficiencies commonly, and you'll see those. And then in some patients, osteoporosis is something you need to be considering, especially in patients that have had longstanding disease. So how do we make a diagnosis? And this takes a combination of multiple things. So you have to take a good clinical history, imaging, pancreatic function testing, and then review of risk factors. There's actually no gold standard for diagnosing chronic pancreatitis, and this is a clinical diagnosis. And when they've looked at it, the most useful diagnostics test is actually a history and physical. So really talking to your patient is quite critical in deciding, hey, we're going to make this decision for chronic panc. And it's putting all of the information together to make that decision. Finally, the ACG guideline does talk about histology as the gold standard. So I just want to make you all aware of that. In patients that you may be suspecting, you can consider a biopsy. Obviously, this carries a lot of risk with acute pancreatitis. And so I think if you can make the decision clinically, it's better. Now, what are complications? And these are complications that you can see from acute pancreatitis as well as chronic panc. You can have pseudocysts, biliary obstruction, duodenal obstruction, splenic vein thrombosis, and pseudoaneurysms. Obviously, a lot of those can be very concerning in the acute setting, but the systemic complications can also be long-term. So we talked about exocrine pancreatic insufficiency, diabetes, osteoporosis, malnutrition, and pancreas cancer. And these are kind of all the things when we're seeing patients in clinic, what we want to be thinking about is how can we prevent some of these things, or at least keep an eye on them. So let's talk about imaging. Imaging is critical. So I think this is how most of our patients will get a diagnosis. And guidelines really recommend either CT or MRI as first line for making a diagnosis. You can pick and choose either one. And most of the time, these patients have had a CT for whatever reason, and that's how incidentally things have been found. But there will be a lot of findings that'll be seen, whether it's calcification, duct irregularity, or strictures that can be found. And MRI can obviously be more helpful in terms of details for duct disease. Now, EUS is a great option, and I'm personally biased because I do like EUS. But the difficulty is it's only useful when the diagnosis is in question, and the sensitivity and specificity of EUS cannot be as perfect, which we'll go about reviewing the criteria in a second. The problem with imaging is we find disease when it's too late. And right now, we just don't have a test to find anything sooner. So it's later stage and irreversible damage at this point has most likely happened. EUS can be sensitive when you're looking for subtle findings, and we'll review that in a second. But imaging really can be a surrogate for histology. And so this is where I would say is, if you take a look at your imaging and you take a step back, can we make this clinical diagnosis without having to do a biopsy? And I would say in most cases we can. So on EUS, if there are any endoscopic ultrasonographers in the room, or you're reading a report, all of these things should be commented on in a report if they're present or lack thereof. And there is a criteria which is called the Rosemont criteria, and I've put this again just for reference. I think it's hard to find actually a very good table that lays everything out, but there's minor and major criteria that are shown in a Rosemont, and we should be describing these in all of our EUSs. To suggest if patients have findings that would either be consistent or suggestive of chronic panc, or do they have a completely normal ultrasound? So let's talk about exocrine pancreatic insufficiency. So not every patient with chronic panc will have exocrine pancreatic insufficiency. And then at the same time, not every patient with exocrine pancreatic insufficiency has chronic pancreatitis. So that's really important, but this can be a sequelae of chronic pancreatitis. And the symptoms will really be steatorrhea, weight loss, and then fat-soluble vitamin deficiencies. So there's a lot of ways that you can do testing. I would say the big takeaway from today should be fecal elastase is the best test. The big thing to also remember is it has to be on a solid stool, which seems crazy because a lot of these patients are having looser stools. But if the patient's having diarrhea and it's just as, it's too loose, they can be a false positive on that. So try to get them to get as solid stool as possible. But I think this is the easiest test to get for patients. And then the treatment is pancreatic enzyme replacement therapy. Now, pancreatic enzyme replacement therapy, it always kind of reminds me of this scene from Scrubs. Let me see if this works.
Did you actually just page me to find out how much Tylenol to give
no
to
sound.
Lenzner?
I was worried that it could exacerbate the patient's
It's regular strength.
Oh, there we go. Yeah, you don't want to hear that. Should we try again? We got it back there. Should I click?
Did you actually just page me to find out how much Tylenol to give to Mrs. Lenzner?
I was worried that it could exacerbate the patient's
It's regular strength Tylenol. Here's what you do. Get her to open her mouth, take a handful, and throw it at her. Whatever sticks, that's the correct dosage. And under no circumstances are you to compromise our no talking agreement.
So that's kind of how I feel like pancreatic enzyme replacement therapy is. You're just kind of like picking a dose and seeing how it works. And that's really not how it's supposed to be. Sorry. Let me pause that now. So if our takeaway for how much you can give, and a lot of the enzyme companies that are out there, you can go on their website and they can help you calculate a dose. But if you walk away just remembering 40 to 50,000 units of lipase, because there's always lipase, amylase, protease, and then you're seeing all these numbers when you look to prescribe it, is if you remember 50,000 units of lipase with each meal, that's a great starting point for most patients. And what you want them to do is take half doses with snacks. And then you want them to take it during meals. So how they take that is not just all 3 pills up front. If they're on 3 pills or 2 pills, you want them to start their meal, take one of the first couple bites, halfway through, take their second pill, and closer to the end, take their third pill. And that way, these enzymes that they're getting, their lipase is actually mixing in with their food to allowing things to break down. Most often, people take everything too early, and then the enzyme is really passed into the duodenum and isn't really working as well. And so you can consider PPI, which will help delay your acid suppression and allow your enzyme to hang out for a little bit longer. And the big thing is that this won't treat pain. And so there is a common misconception that putting people on pancreatic enzyme replacement will help their pain, but it won't. And so then monitoring their weight, their nutrition levels, and then vitamins. I usually check fat-soluble vitamins A, E, D, and K every 6 months, especially if someone was having really severe symptoms, and then kind of move to a more annual basis after that. And so let's talk about pain management. So you want to try avoiding opiates, which is really tough in our adult population. There is some evidence for antioxidants, but it's really inconsistent. And so your approach to pain management really is lifestyle modifications, non-opiate use, and neuromodulators. And if you can get someone into a chronic pain clinic that can help with this, that can be super helpful. And then endoscopic therapy and surgery, which we'll talk about. So lifestyle modification is critical. I really, at every visit, emphasize smoking cessation and alcohol abstinence kind of routinely, just so patients know. And then getting a dietitian involved can be very helpful. And then exercise, and then treating depression and anxiety, because there is a significant mood disorder overlap with a lot of these patients, which could also maybe explain some of their alcohol dependence. And so kind of getting to the bottom of that is also quite critical. Let's talk about endoscopic therapy really quickly. When to consider it is kind of anytime you either have obstruction or a duct stricture. And what are our options? So I won't belabor all of these, but there's a lot that we can do. And so it's reasonable to consider treatment, and we can do EUS-guided celiac plexus blocks for pain management for a lot of these patients. When referring someone, though, for this, if they're still actively drinking, you really have to be thoughtful. And, my personal approach is in patients that are actively drinking, I don't do pancreatic duct therapy in these folks. If there's something else like a pseudocyst, I think it's reasonable to do, but alcohol can really compound what we're trying to fix. And so one of the big things that we talk about in clinic is alcohol cessation prior to pursuing any endoscopic therapy. Let's talk about surgery. Indications include severe pain, prior failed endoscopy, or if there's suspicion for malignancy or inflammatory head mass. These patients can be hiding malignancy, and if you have concerns, sending someone to surgery is reasonable. There's a lot of options that exist, and our pancreatic surgeons here are quite talented. And one of the things that we're working on currently is actually getting a program for total pancreatectomy with islet autocell transplantation, which we're hoping to have up and running in the next several months. But we're in the process right now with our peds colleagues as well on getting this. And so this pains my heart a little bit as an advanced endoscopist, but is the reality. There was a randomized control trial that looked at endoscopy versus surgery. And what it found is they took patients in both groups for early surgery and endoscopy first. And the primary outcome was actually looking at pain scores, and early surgery was actually quite significantly better. And the reason why this matters is if a patient is a good candidate for surgery, early surgery can really help with better pain control and can help break that chronic pain cycle, which sometimes can be irreversible. And so referring a patient to a surgeon to consider surgery in the right patient can be very helpful. It can also allow for fewer procedures and ERCPs, which carry a risk of acute pancreatitis as well. Pancreatic cancer, finally, there is a significant increase in all of our patients, 5 to 10-fold, especially if they have hereditary pancreatitis or tobacco use. There's no guidelines for surveillance. And so my personal practice is every couple of years, if there hasn't been some sort of imaging, is to consider it, especially in patients that are newly being sent to me. We're looking at imaging and considering an EUS, but there is no guidelines, and I'm hoping we'll probably get some clarification soon. So I won't go over all of this, but this is kind of our management algorithm that you all should consider and treating our patients. And then let's just go over some quick take-home points. Again, this is a complex fibroinflammatory disorder requiring multidisciplinary care. You have to make a clinical diagnosis. There won't be one slam dunk answer. I think imaging can be very helpful. EUS is also an early stage disease if you're looking for something or diagnosis is in doubt. Really stress smoking and alcohol cessation. Pancreatic enzyme replacement therapy will be helpful, but won't treat patients' pain, and use multidisciplinary pain management. And then surgery shouldn't be delayed for the right patient, and then look for cancer in the right folks. So for a more formal version of chronic pancreatitis from ChatGPT, this is what it recommended before the comic. But if there is one page you want to reference, look at this. Kind of covers almost everything in terms of what you want to know about chronic panc in a nutshell, and should help you take care of most of your patients. Thank you for listening, and we'll answer your questions once we're done.
All right, thanks, Sean. That was a scary pancreas image.